Welcome back. Now we'll talk about chest medicine. First, most important thing is to identify what kind of chest infection or the chest problem he's got. Is this patient got a restrictive lung problem or an obstructive lung problem? When you think that this patient has got when you do a clinical bedside examination, if you think that this patient has got a sputum pot with copious amount of sputum that is being produced, it is bronchiectasis or patient who might be having a COPD with infective exacerbation. All right. Bedside, you can perform peak expiratory flow rate as well. All right. First, we'll talk about the spirometry. If it is an obstructive pattern, the ratio of FEV1 by FVC is reduced, usually seen in asthma and COPD. The difference between asthma and COPD is it is irreversible in asthma, sorry, it is irreversible in COPD, and it is a reversible condition in asthma. Talking about the restrictive lung disease, the restriction is basically because of the lung expansion that is restricted. That is why we call it as a restrictive lung disease. The ratio of FEV1 by FVC can be normal or can be high in restrictive lung disorders. All right. In obstructive lung disease, what happens is the expiration is usually affected. So the air will be trapped in the lung. So the residual air is increased and the total lung capacity is increased. That is why in obstructive lung disorders, the total lung capacity and the residual volume is increased. Whereas in restrictive lung disorders, it is the total lung capacity and the residual volume that are decreased because in restrictive lung diseases, there will be restriction of the lung that is not expanding. All right. You can see the table here. He's able to mention that the spirometry results that are being interpreted, which are normal, is the FEV1 of more than 80% and FVC of more than 80%, and the ratio is 75 to 80 in normal patients. Talking about the restrictive, the FEV1 is less than 80%, FVC is also less than 80%, and the FV1 by FVC ratio is more than 70% in restrictive lung disorders. Talking about the obstructive lung disorders, the ratio of FEV1 by FVC is less than 70%. That is what we will have to understand. There is this amazing concept of gas transfer. Remember, if you want to check the transfer efficiency or the gas transfer efficiency between the lung and basement membrane, it is basically calculated as TLCO. It is low in emphysema or it is low in interstitial lung disorders, and if there is any pulmonary vascular disease. Whereas the lung efficiency to transfer the gas or transfer the oxygen will be high in alveolar hemorrhage, because in alveolar hemorrhage, the patient who have got the hemorrhage, the blood vessels will be there. That is why the blood vessels will be there ruptured, and there will be RBCs that are present at the alveolar level that can cause the transfer of the oxygen to the tissues. That is why in alveolar hemorrhage, the lung function tests are increased. All right. Next, we talk about other investigations. First, most important investigation, radiological investigation, is a chest X-ray. The blood investigation is an ABG. If you want to identify the pulmonary fibrosis disorder, it is usually a CT scan, please. All right. All these are important for uh, MRCP part 1. I'll tell you how to, I'll talk about the ABGs later. First, we talk about asthma. We all know that the asthma is an reversible disorder. Asthma is a reversible disorder. It is a type 1 hypersensitivity disorder, and it has got an inflammation that's been going on for a long time. So it is a chronic inflammatory type 1 hypersensitivity with reversible character. Most importantly, the symptoms of asthma are cough, wheeze, shortness of breath, and chest tightness. I also want to mention you that the cough, which is usually predominant at night, is characteristic of asthma. That is one thing you will have to remember, please. When you examine a patient with asthma, what do you think of? You'll think of an expiratory wheeze on auscultation, and if you do a expiratory flow rate, there will be reduced peak expiratory flow rate. All right. I also want to tell you that the clinical presentation of asthma can be different given that the patient can be having a different respirants such as dust pollen, allergens, infection, irritants, and NSAIDs, or sometimes it can be aspirin induced asthma as well. There can be various clinical patterns such as diurnal variations where the symptoms are worse at night. Sometimes there can be an occupational link where the patient who is not going to work on Saturday and Sunday can be normal, usually called as a Monday morning disease, where the patient can go to work on Monday as well. Next, we talk about some of the associated conditions which can give us a clinching diagnosis of asthma in PLAB1 exam. Most of the patients are usually associated with eczema and hay fever. And remember, if the patient who is not got any eczema and hay fever, but still complains of night cough, could be associated with what is the one thing that is associated with? It is basically associated with GERD. GERD is the one most important thing you must not forget while evaluating asthma, please. How do you diagnose asthma? One most important thing. I also want to consider before diagnosis the risk factors for asthma. In the question, the examiner can tell you that this is associated with type 1 hypersensitivity. So it is usually associated with IgE mediated conditions or eczema or allergic history. Sometimes there can be history of mother smoking around the child or father smoking around the child or both smokers excessively smoking at home. That is one thing the patient can develop asthma. Sometimes there can be winter seasons, autumn seasons, summer seasons where there is pollen exposure or perfume exposure, or sometimes house dust mite can also trigger asthma. Most of the times, allergic asthma, that is basically because of the NSAIDs, beta blockers, and aspirin that can cause asthma as well. If we are talking about the diagnosis, most importantly, the high probability is obviously the symptoms. But the diagnostic test is, if there is diagnostic test, spirometry with the reversibility is one most important thing we are doing. And how do you diagnose spirometry test with reversibility? If you give a bronchodilator and if you ask the patient to do a spirometry, there will be more than 12% improvement in FEV when after the bronchodilator has been given. This is how you differentiate between asthma and COPD. I also want to tell you that peak flow monitoring can be done, but the peak flow monitoring duration needs to be more than 15%. That is, in the morning, it is if it is normal, and in the evening, if the patient has got night asthma, it will be 15% reduced. That is what the peak flow monitoring is. If the patient has got type 1 hypersensitivity, atopy, and has got asthma, fractional exhalation of nitric oxide can be done. That can be used for diagnosis as well. And what does this fractional exhaled nitric oxide measures? It measures eosinophilic inflammation, please. Very important. All right. What is the test that is used to distinguish between COPD and asthma? It is the spirometry with the reversibility that needs to be done, please. All right. What are the differential diagnosis of asthma? First most important thing is obviously COPD. Sometimes, not sometimes, most of the times, asthma is associated with wheeze. So, wheeze could be a differential diagnosis for other conditions as well, especially if the child has got focal wheeze, that indicates that the patient has got a foreign body ingestion. All right. Very important. Most importantly, patient who is presenting with the shortness of breath, pulmonary embolism, and pneumothorax and bronchiectasis can also be considered as the differential diagnosis. Next, we talk about some of the management. If you want to manage this patient, obviously you will have to do a pulmonary function test. When the pulmonary function tests are being done, When you do an FEV1, the FEV1 is reduced in asthma because it is an obstructive lung disorder. Whereas FVC, it is normal. And the ratio of FEV1 by FVC, as the asthma is an obstructive lung disorder, it is basically decreased. All right, isn't it? And then if you are doing a fractional excretion of nitric oxide or something like that, fractional excretion exhaled nitric oxide test, I would say that it is usually more than 40 parts per billion is what we will have to remember. All right. Next, we talk about the management of asthma. Please do remember that the management of asthma is very important. If the patient has got a chronic asthma, we'll have to see stepwise pharmacological management. And if it is an acute attack, you'll have to treat it with bronchodilators. All right. If the patient has got chronic asthma, first most important step is lifestyle and education. Make sure that he avoids smoking, avoids triggers for the exacerbation of asthma as well. If the patient is started on bronchodilator and is not responding to asthma, please make sure that the patient is using the inhalers in correct technique. Talking about the long-term management of asthma, I want to discuss about two most important things. One is the NICE guidelines and another one is the British Thoracic Society guidelines. The first guideline, first we'll talk about the NICE guidelines. It is short-acting beta agonist such as salbutamol. If it is not responding, you can give short-acting beta agonist and low dose of ICS, that is beclomethasone. If the patient is not responding to short-acting beta agonist and low-dose inhaled corticosteroids, it is again the leukotriene receptor antagonist that we will have to do. Next, we talk about short-acting bronchoagonists with inhaled corticosteroids and long-acting beta agonist is one most important thing, with or without long-term or leukotriene receptor antagonist is one another thing. If the patient is not responding to any of these things, you'll have to refer to the specialist. This is asked in previous PLAB1 exam. Please do remember that. The NICE guidelines, it mentions that the first thing is short-acting beta agonist, short-acting beta agonist with low dose inhaled corticosteroids. And then if the patient is not responding to short-acting beta agonist with low dose corticosteroids, you'll have to add a leukotriene receptor antagonist. If the patient is not responding to short-acting beta agonist, low dose inhaled corticosteroids, leukotriene receptor antagonist, you will have to add long acting beta agonist to that. If the patient is not at all responding to that, you'll have to refer to the specialist or you can also add theophylline. Now, coming back to another guidelines where British thoracic guidelines are important. So this is what we discussed. British thoracic guidelines, when we do that, you will have to make sure that a low dose ICS needs to be, this is British thoracic guidelines, low dose ICS such as formoterol or beclomethasone can be given. Sometimes if it is not, you can give low dose ICS and also SABA, or sometimes you can also give low dose ICS formoterol as well. Step 3 is moderate persistent. Then you can add low dose ICS, LABA, maintenance and reliever therapy as well. The medium dose ICS, LABA, maintenance and reliever therapy, you can add LAMA or leukotriene receptor antagonist. For step 5, it is usually the high dose ICS with the LABA, or you can refer to the specialist, please. Could you all please take a screenshot or a snapshot of this, please? This is very important. This is most updated guidelines, please. All right. I'll give some time to take a screenshot. All right. Next, we talk about some of the exacerbations of asthma. Most importantly, I would like to discuss about exacerbation of asthma in adults first. Whenever there is an exacerbation of asthma in adults, first, most importantly, oxygen therapy needs to be given and salbutamol nebulizations must be given. After that, add corticosteroids. It is usually in the NHS, we prescribe prednisolone 30 milligrams for 5 days. And if the patient is too unwell not to take any of the things by oral, we will give IV hydrocortisone 100 milligrams if he is not able to take anything orally. You will manage this patient if he's got an exacerbation of asthma and if the patient is not responding or you think that this patient's asthma is getting worse, you will have to make sure that a salbutamol nebulizer for every 15 minutes needs to be given with ipratropium bromide of zero point 0.5 milligrams. Very important. And then you can also add magnesium sulfate IV over 20 minutes. The examiner can ask you about the dose of the magnesium sulfate. It is 1.2 to 2 grams, please. All right. Once the patient has been given, this patient has been stabilized, you can shift him to the ward and continue salbutamols every 4 hours, please, and continue oral prednisolone for 5 days. What if the examination mentions that the patient is not responding to oxygen, salbutamol, corticosteroids, hydrocortisone, prednisolone, or salbutamol nebulizations every 15 minutes, or patient who is not responding to magnesium sulfate over 20 minutes? What do? You will have to make sure that the patient has been given a call to the ITU or the high care dependency unit. So escalation of the care is the most important thing, please. All right. Next, we talk about exacerbation of asthma in children. In children, it is the same, but I want to make sure that the corticosteroids you give it in the liquid form, please. All right. Next, we talk about the exacerbation of children. Even though it is same, I'll repeat it again. Please make sure that the oxygen needs to be given, salbutamol nebulizations needs to be given. After that, a long-acting or an ipratropium bromide needs to be given. Then corticosteroids needs to be given. If the patient is not able to swallow, IV hydrocortisone needs to be given. If the patient is not getting better, you can give IV salbutamol, IV magnesium sulfate, or IV aminophylline as well. Meanwhile, the examiner can ask you one question: what is the next best step you do after treating a patient with exacerbation of asthma in children with oxygen, salbutamol, ipratropium, corticosteroids, or IV hydrocortisone? You will have to get a ABG to assess if the patient is improving or not. If the ABG shows that the patient is worsening, you will have to either add IV salbutamol, IV aminophylline, or IV magnesium sulfate, please. We will now talk about some of the complications of asthma as well, because complications of asthma can present as anything. It can affect either the chest or the heart or the brain. Why? Because if the patient has got acute exacerbation of asthma and if it is not treated promptly, there can be altered mental status with drowsiness. Sometimes the asthma, if it is severe, there can be poor respiratory effort as well. If the patient has got severe asthma, the patient can develop cyanosis. The patient can develop hypotension as well. And on ABG, if you take an ABG, how do you differentiate that this patient has got severe asthma? Remember, if PaCO2 is normal with oxygen saturations of less than 92%, it is severe asthma, please. In asthma, PaCO2 must not be normal because you keep on hyperventilating. The patient keeps on hyperventilating. If the patient has got hyperventilation, what do? The CO2 is all lost. If the CO2 is all lost, the CO2 reduces, but CO2 will never be normal. But in severe asthma, it is the PaCO2 that is normal and the saturation of oxygen that would be normal. Sometimes, if the asthma is severe, there can be arrhythmia as well. The patient is usually exhausted and can develop altered mental status with drowsiness as well. All right. Next, we talk about COPD. Give me a 2 minutes break and I'll come back. Welcome back, everyone. Now we'll talk about COPD. Obviously, we all know that COPD is an irreversible condition with an obstructive element. So, it is FEV1 by FVC of less than zero point 0.7 post bronchodilation. Obviously, this would be an outstanding characteristic point for the differentiation of asthma and COPD. If you want to talk more about COPD for PLAB1, it is the most common risk factor is smoking. Smoking is the most important risk factor, followed by air pollution, which can be indoor or outdoor. Sometimes it can be occupational exposures as well. There can be an element of alpha-1 antitrypsin deficiency, which most of the students do not answer in PLAB1 because the examiner can give you a tricky question saying that a 21-year-old male patient develops COPD after smoking 5 or 6 cigarettes for over 6 months and then he's developed COPD. What do you think of it? Is alpha 1 antitrypsin deficiency the patient has got if the patient is not able to recover fully. This patient has got COPD because alpha 1 antitrypsin deficiency is present. There will be so much of elastase activity that will be going on, and then COPD will be developed rapidly. That is very important. When the COPD patients develop, the symptoms are usually cough, wheezing, and there will be obstruction of the airway. And when there is obstruction, there will be entrapment of the air. That is when you find that there is hyperinflation on the chest x-ray. Sometimes the COPD can also be causing hoarseness of the voice because of the smoking conditions, please. All right. Next, we talk about the clinical presentation. Whenever there is clinical presentation, it is the chronic cough with the sputum production, dyspnea, and wheezing the patient usually has got. The examiner can tell you that the signs present are tachypnea, that is increased respiratory rate with wheezing. Remember, focal wheezing is foreign body as long as you are going for an UK exam. And diffuse wheezing is basically asthma and COPD, please. Obviously, the clinical presentation can also be presenting as a complication. All right. How do you diagnose COPD? It is the post-bronchial spirometry, which we usually do, and FEV1 by FVC ratio of zero point 0.7 or less than 70. And FEV1 will be less than 80% because this is an obstructive disorder and there can be increased total lung capacity and increased lung volume because of the air trapping. Please do remember that sometimes if patient has got COPD and if you give the bronchodilation, the examiner will tell you only sometimes the examiner can tell you that the bronchodilation effect has not shown any improvement in spirometry. The examiner will not give you the value. Even though the examiner has not given the value, it mentions that the bronchodilatory response of FEV1 by FVC ratio has not improved. It is usually COPD, please. All right. The chest X-ray, when you do a chest X-ray on COPD, it is usually hyperinflation with presence of flat hemidiaphragm and there can be more than 7 posterior ribs that are usually seen on chest X-ray. How do you manage, first you'll have to make sure you get the bloods done on the bloods. Because of the increased smoking and increased hypoxia, there will be increase in the erythropoietin that can usually cause increase in the hemoglobin level. That is one most important thing. So first most important symptom is you will have to make sure that the smoking cessation is usually done. Okay, and the bloods we usually do is a increase in the hemoglobin, that is also called as polycythemia. All right. Tell the patient that he needs pulmonary rehabilitation if you think that the patient has got COPD. All right. Next, we talk about the management of COPD. First, most important thing, advise the patient to stop smoking. Next, you go ahead with short acting beta agonist or short acting muscarinic agonist. If the patient is not responding, you can add long acting beta agonist and also long acting muscarinic antagonist, or you can add steroids at this point of time. The steroids which you add are inhaled corticosteroids, please. Sometimes, if the patient has not been responding, you can just continue long acting muscarinic agents, long acting beta agonist, and inhaled corticosteroids. And if the patient is still not responding, you can go ahead with theophylline therapy, please. All right. The most important question is the examiner can ask you about the oxygen use in COPD. When do you use oxygen, or the long-term oxygen therapy is usually indicated if the patients are clinically stable and if the patient is not smoker. Why is it? Because if the patient is smoker and if the patient is on oxygen, there can be fire accidents by the oxygen cylinder as well. So long-term oxygen therapy, if it is PaO2 of less than 7.3 or PaO2 of 7.3 to 8 with evidence of complications of right heart failure such as pulmonary hypertension, cor pulmonale, and polycythemia, you will have to consider long-term oxygen therapy. Sometimes the examiners can also give you the tricky questions about long-term oxygen therapy or indications about long-term oxygen therapy. If the patient has got raised JVP with the peripheral edema that is present, or polycythemia or cyanosis, and oxygen saturations are less than 92%, or if the patient has got a FEV1 of less than 30 and FEV1 of 30 to 49%, it is an indication of long-term oxygen therapy, please. And the next question the examiner can ask you is, patient is already started on long-term oxygen therapy, but the patient has not got any improvement with long-term oxygen therapy. What do? You will have to put him on steroids, and then you will have to make sure that there are no other secretions in the lung, just to make sure that the oxygen and the prednisolone and the normal saline are able to work for the breakdown of the secretions to lose the secretions, and the oxygen is working effectively. That is one most important thing. And remember, the goal for long-term oxygen therapy is you'll have to use it at least 15 hours per day to improve the survival, please. All right. Next, we talk about some of the management of COPD. When do you want to do an exacerbation of COPD management? How do you manage an exacerbation of COPD? You'll have to make sure that an oxygen is used, but only use up to 24 to 28% of oxygen. You must not use 100% of oxygen. Use 24 to 28% oxygen, but please do make sure that the O2 saturations are between 88 to 92. Remember that. And whenever you start oxygen, you start the short acting bronchodilator as well. You can use prednisolone 30 milligrams if the patient has got COPD exacerbation. Again, it is the same for asthma as well. If the patient is not able to swallow, you can give hydrocortisone 100 milligrams as well. If you think that the patient has not got any response, you can continue with IV aminophylline. Say, for example, if the patient has got an history of COPD and now the patient is presenting with fever, think that the patient has got an infection and please start antibiotics. What is the most important exacerbation cause or exacerbating factor for COPD? It is the infection. So always consider antibiotics if the patient is presenting with fever, cough, sputum, and raised inflammatory markers. If you treat the patient with antibiotics and steroids and bronchodilators, still the patient is not improving, you will have to make sure that you need to ring the ITU or high care respiratory unit just to make sure that there is non-invasive ventilation that needs to be administered, please. All right. This is one thing you will have to remember, please. All right. Next, I also want to tell you that there is a variant of COPD where we usually see in heavy smokers. It is called as chronic bronchitis. This is usually a variant of COPD, but in chronic bronchitis, it is the bronchi that is affected, but not the pulmonary things that are affected. That is the matter of the lung or the parenchyma of the lung is not affected. That is very important. For you to diagnose chronic bronchitis, there must be cough that usually lasts for 3 months, or there can be progressive shortness of breath. If you think that this patient has got wheezing with productive cough for more than 3 months, for more than 2 years, you'll have to think of chronic bronchitis. And what is the most important risk factor for chronic bronchitis? It is usually the smoking that causes chronic bronchitis. Examiner can ask you about when to refer to a specialist in patients who has got COPD. It is usually by the onset of cor pulmonale, patient not responding to usual medications. And if you think that this patient needs assessment for bullectomy or lung volume reduction, you'll have to refer this patient to a specialist. All right. We'll take 2 minutes and then we'll discuss about pneumonias. Hi. We'll now start with pneumonia. May I please ask you guys to exit if you have not paid for the fees or subscribed for the course. Thanks very much. All right, welcome back. Now we'll talk about pneumonias. Pneumonia is obviously an infection of the lung parenchyma. So the function of the lung is to make sure that there is sputum production. Whenever there is infection, patients do have fever, cough, and there can be sputum production as well. Please do remember that when you examine a patient with pneumonia on auscultation, you will find basal crackles. Oh, give me a minute.